Bismillah, Assalamu alaikum. This is Khalid Alnajjar again, and this session will be dedicated towards parathyroid gland. I will be digging deep into its regulation, or the regulation of calcium, its anatomy, physiology, histology, and I will be explaining and differentiating between the confusing diseases and syndromes regarding parathyroid gland. We will also talk about the phosphate metabolism, inshallah. This is basically a continuation of my previous recording if you attended it, which was about the thyroid gland. And down here, again, I will repeat this again. Here, down here is my information, my email, and my phone number. If you have any question regarding this lecture, the previous lecture, please let me send me. Don't hesitate. I will be more than happy to help, inshallah. Yep. So to kick off, let me again just show this is the thyroid. Let me tell you about the anatomy of the parathyroid gland. This is the thyroid gland, the big red pink thyroid gland. Those small yellow balls, sort of balls, are the parathyroid glands. We have four of them, two superior and two inferior. The two superior glands are called the two superior are called the parathyroid 4. Why? Because they arise from the fourth pharyngeal pouch. The two inferior parathyroid glands, along with the thymus, arise from the third parapharyngeal pouch, hence called parathyroid 3. So the superior comes from the fourth, parathyroid 4, inferior comes from the third, hence called parathyroid 3. And the major blood supply to the parathyroid glands are the inferior thyroid artery, which comes from the thyrocervical trunk. Okay. This is histology, basically histology slide of the parathyroid in the capsule of the thyroid. This is how it looks like. This is a ball, basically. This is right. This ball is basically this. There are under the capsule of the thyroid, there are multiple cells in the septa. We will zoom in now. Yes, this is a zoomed in slide into the or a higher magnification into the parathyroid gland. We have oxyphil, we have oxyphil cells, we have principal cells. This is a blood vessel, and principal cells or chief cells, which are these dark colored. They are small cells with central nucleus. That's why they appear blue or bluer than the oxyphil cells. And they appear eosinophilic with an eosinophilic cytoplasm with vesicles containing the parathyroid hormone. These are the parathyroid hormone is secreted from the principal cells. However, the oxyphil cells are larger cells. They are less in number and pink with stain. That's and we don't know their function. Basically, they're just there. Okay, this is an adipose tissue. This white AC here is an adipose tissue. They increase in number with age. They are present in the parathyroid gland. Okay, this is another magnified slide. It shows that P is principal or chief cells which secrete the parathyroid hormone. Adipose tissue. This has quite more adipose tissue than the previous one, so I would expect this patient to be older than this patient, by the way. Chief cells, you see how they are pinker than the principal cells. Yeah. Sorry. This C stands for a capillary. Why did I mess up? This C stands for a capillary. So this is blood. You can see how blood lumen and around it is the endothelium. P is principal cell. You see how they are purple. O is oxyphil cell. So it's pinkish. You see how it's looks pinkier than or lighter than the principal cell. Again, this is under another slide. This is a clearer slide. This is hidden here. These are the principal cells. These are the chief cells. Yeah, you see how, what is my, let me just pull up a laser pointer. You see how these appear blue and these appear pink, or appear pink under stain, yeah? So these are the oxyphil cells and these are the principal cells. Like forms of calcium in blood. Now, you know the parathyroid hormone is is the main hormone responsible for calcium or regulation of calcium in the blood. Okay. Before I start talking about the calcium homeostasis and calcium regulation in the blood, I want you to know about the calcium forms in the blood. Okay. Let me zoom in. This is a very nice classification. Total calcium in our blood is divided into protein bound and ultra filtrable. 40% of it is protein bound, basically, and 60% of it is ultra filtrable. Okay, the 60% is 10% of it is complex to anions, and 50% of it is ionized calcium. And the ionized calcium is the active calcium. Remember from the previous lecture, the protein bound. Most of the hormones that are protein bound are inactive. The active form of a hormone is hormone molecule, whatever, is the ionized form, or is the ionized or the activated form, especially here in calcium. In this slide, he's trying here to say what could go wrong or what could change the plasma levels of calcium. So for example, for the first one, if we increase the phosphate, before explaining this, actually, I want you to keep in mind this. Whenever calcium is in the blood, it is usually or whenever phosphate is in the blood, it is usually bound to calcium, which is this 10% complex to anions, okay? Usually phosphate runs with calcium. So if you read this, he's trying to tell you if we increase phosphate in the blood, the bound calcium increases since negatively charged phosphate binds with positively charged calcium, okay? That's why they are always together. Hence, free calcium will decrease because remember, only free is the active one. And if we decrease the active, this will affect the parathyroid hormone or the PTH. And again, the PTH is the main hormone responsible for the homeostasis of calcium. Okay, so he's basically trying to say decrease in active calcium will increase the PTH secretion, and I will explain why now in the upcoming slide, inshallah. And how will we decrease the active ionized calcium in the blood? If we had more phosphate in the blood, because phosphate almost always binds to calcium. The next one here, he's trying to say, so how the acidity and the basic levels of the blood affect calcium. How I will explain now. If we have more hydrogen ions because of acidemia, acidemia, we have more hydrogen ions. Albumin, these hydrogen ions will bind to albumin. Why? Because albumin is negatively charged and hydrogen ions are positively charged. So they will bind to albumin. So fewer sites of calcium, fewer sites on the albumin will be free for calcium. Hence, most of the calcium will be free and active and ionized. Hence, we have hypercalcemia. However, in alkalemia, we have less hydrogen bound to albumin. Now we have more free spots for calcium to bind to albumin. So all of the calcium will be bound to albumin and less free calcium will be in the blood. Hence, we have hypocalcemia. And this picture right here explains it very well. This is the albumin. In case of acidemia, we have more hydrogen. So more hydrogen binding to albumin, occupying most of the spots on the albumin, keeping fewer slots or spots for calcium. Hence hence more ionized or free calcium, which is hypercalcemia. Again, this is the only effective and active one. Again, in alkalemia, less hydrogen occupying albumin spots, leaving the slots empty or free for calcium to occupy. More calcium or more free and ionized calcium will bind to albumin, hence keeping the blood with less ionized free calcium, which is hypocalcemia. That's basically it. And this is a page from first aid. You can read it really quickly, but I explained it all. Right. Now let's dig deeper into calcium homeostasis. Basically, as I mentioned before, calcium homeostasis is our PDH is the main has the largest effect in calcium homeostasis. In our body we get calcium from three main sources: intestines or GI, kidneys, and bones. How? In the kidneys, or let's start with GI, the easiest. In GI, we absorb calcium from our diet, okay, or secrete it, maybe. But usually we absorb it into the extracellular fluid. And from the bones, we have bone reduction. Bone reduction will cause more calcium and phosphate, or more bone resorption will cause more calcium and phosphate into the extracellular fluid, increasing calcium. In the kidneys will have its effect through calcium reabsorption again. Okay, so these are basically the three sources of calcium. And we want to see how PTH affects every one of them in the following slides. Let me touch briefly on it really quickly. PTH basically is the one that makes the kidneys reabsorb calcium and excrete phosphate. PTH is also the reason behind increase in bone resorption. Okay, and bone resorption, any osteoclasts working, and they are digging in the bones and eating the bones and secreting the calcium and the phosphate to the extracellular fluid. Or another function for PTH in the kidneys is they stimulate the function of the enzyme 1-alpha hydroxylase. What is the function of this enzyme, or what is the action of this enzyme? It basically activates vitamin D. So we have the form of vitamin D, which is 25-hydroxycholecalciferol. This is the inactive form of vitamin D. 1-alpha hydroxylase activates this form of vitamin D, or changes it into 1,25-dihydroxycholecalciferol, and this is the active form of vitamin D. What does the active form of vitamin D do? It also aids in the bone resorption, or it stimulates the osteoclasts indirectly, to resorb the bone, and it also enhances the absorption of calcium. And yeah, this is briefly touching on it. Now I will be explaining it in more details. This slide is basically talking about the structure of the parathyroid hormone and how it is synthesized. It's way simpler than how the thyroid was synthesized. Thyroid synthesis is a bit more complicated. We basically here start with the chief cells, or the principal cells of the parathyroid, synthesize and secrete PTH, a single chain polypeptide of 84 amino acids. That's PTH. How do it start? It starts with the synthesis on the ribosomes as pre-pro-PTH, which has 115 amino acids. Then remove 25 amino acids from this 115 through cleavage. You have 90 remaining. This 90 will go into the Golgi apparatus. 6 will be removed or cleaved again, yielding to a final 84, which is the polypeptide with 84 amino acids, which resembles PTH. 84 amino acid form of the hormone. PTH is packaged in secretory granules for subsequent release. Nothing too hard here. The regulation of PTH secretion. Okay, regulation of PTH secretion on the parathyroid gland. As I mentioned before, parathyroid hormone, or PTH, has the largest effect on calcium homeostasis and regulation. طيب. That's why decrease in calcium will increase PTH secretion. We have receptors in the PTH gland, small receptors, that sense the decrease of calcium in the serum. Whenever they sense this decrease in serum calcium, they get activated, or they basically activate PTH secretion and synthesis. PTH is secreted, and PTH carries out multiple activities, the ones that I explained in the previous slide, or two slides before, in order to restore the calcium levels, basically by affecting the intestines, kidneys, and bones. طيب. What is another thing that would affect PTH secretion? Increase in serum phosphate. Okay, remember how PTH increases phosphate excretion? Or in other words, it decreases phosphate reabsorption. So it aids in the excretion of phosphate into the urine. And one way I try to remember this is PTH. It stands for phosphate trashing hormone. Literally kicks out phosphate from your body through urine. Okay, that's why increase in serum phosphate will stimulate PTH secretion in order so that PTH will go and excrete or activate the kidneys so that they excrete phosphate. This has a huge role, by the way. I will explain now the physiology behind it. Decreased magnesium will increase PTH. They found that magnesium has a very similar effect of calcium into PTH. So whenever you have decreased magnesium, you will have increased PTH. This will be explained in the following slide, but just memorize it. Magnesium has a very similar function to calcium on PTH, or similar effect on PTH of calcium on PTH. Decreased magnesium will increase PTH secretion. Decreased calcium will increase PTH secretion. However, severe hypomagnesia or severe decrease in magnesium will decrease PTH. If we compare it to calcium, severe decrease in calcium or severe hypocalcemia will increase PTH more. But in case of magnesium, this is different. And common causes of decreased magnesium is diarrhea, alcohol use, diuretics, and so on. This slide basically summarizes what I said, exactly what I said. It does not have magnesium here. Magnesium is in the two coming slides, inshallah. The only thing I might have missed here is the parathyroid cell membrane contains calcium sensing receptors, the ones I talked about. They are linked via G protein to phospholipase C. So whenever they sense, let's read it. When the extracellular calcium in concentration is increased, calcium binds to the receptor and activates phospholipase C. The activation of phospholipase C leads to increased levels of IP3 calcium, which inhibits PTH secretion. This is kind of it has an opposite effect, basically. So how do those amazing calcium sensing receptors sense that there is less, or sense that there is less calcium in the serum, so PTH should be excreted by an opposite way? They are there to sense hypercalcemia and to turn off PTH secretion. Whenever they don't work, they will not turn off PTH secretion, or they will not turn off PTH or parathyroid gland, and they will excrete more parathyroid. Okay, this is what I mean by opposite. This is what I mean by opposite effect. Yani, again, real quickly, calcium sensing receptors are always there only to sense hypercalcemia. Whenever there is hypercalcemia, calcium will bind to this receptor, and this receptor will work by activating IP3 phospholipase C throughout the process to activate phospholipase C, which will increase the levels of IP3 and calcium, and this will inhibit PTH secretion. Okay, this is the normal for calcium sensing receptors. Whenever calcium levels in the serum drop, there is no calcium to bind to the sensing receptors. Hence, nothing will turn off the parathyroid gland, and the parathyroid gland will start working and secreting PTH. That's how the parathyroid gland knows that our senses that there is lower levels of calcium. Hope this is clear. This is just a relationship between calcium concentration and parathyroid gland. You see, whenever this the x-intercept is for calcium, y-intercept is for PTH. Whenever the calcium is low, see up until 12, and that's the normal levels of calcium, the PTH is high. Okay, in order to restore the levels, and you can tell here that it is smart. If we have a mild hypocalcemia, we don't need 100% rate of PTH. We just need almost 60, 70. You get what I mean? It's small. It's not like we secrete PTH and that's it. Regulation of PTH basically here they are repeating what I mentioned. The next slide will be the explanation. However, this is the magnesium that I talked about. You see, it has parallel, although less important, effect on PTH secretion. Thus, like hypocalcemia, hypomagnesia stimulates PTH secretion. and hypermagnesia inhibits PTH secretion. يعني similar effect to calcium. An exception to this is severe hypomagnesia associated with chronic magnesium depletion. That's such in case of alcoholism, for example. Severe hypomagnesia inhibits PTH secretion. That's it, complementing the inhibitory effect of increased plasma concentration on PTH secretion. That's it. Okay, now on to this slide. This slide basically summarizes the whole lecture, or the most important part of the lecture, which is what happens to PTH and what happens to our bodies in cases of hypocalcemia when we don't have calcium. Okay, let's spend some time on this slide, explain it well. You have to understand it from this slide, and then the following slides will be literally a sip of water, not even a piece of cake. A sip of water, because they will be an explanation to whatever I explained here. Like, we have low calcium levels, hypocalcemia in our body for any reason. Okay, low calcium or hypocalcemia. Now, as I explained before, the parathyroid gland, the way the parathyroid gland works or senses that there is hypocalcemia is that there is nothing shutting it down, or the calcium sensing receptors are not sensing calcium in the blood, so they are not shutting down or turning off the parathyroid gland, removing its effect. And then the parathyroid gland is working and kicking off, depleting parathyroid. Okay, that's what they're saying here. Decreased ionized calcium, or active form of calcium, or increased phosphate, or decreased vitamin D. Any of these three states will activate the parathyroid gland to secrete PTH. Now we have PTH in our circulation. PTH will go PTH will go to the kidneys. It will increase calcium reabsorption. It will stimulate the kidney to reabsorb the calcium from the urine, and it will decrease phosphate reabsorption. It will force the kidney to excrete phosphate into the urine. Okay, that's effect number one. Effect number two on the kidneys is it will increase the activation of vitamin D. How? As I said before, through the stimulation of the enzyme 1-alpha hydroxylase, which is present in the kidneys. This enzyme activates vitamin D. Okay, and this enzyme will also uh, has an effect on the kidneys of calcium reabsorption and phosphate excretion. Look at it here. So PTH effect on the kidney is increased 1,125 hydroxycholecalciferol, which is the active form of vitamin D. It increases its synthesis. How? By activating 1-alpha hydroxylase. 1-alpha hydroxylase will activate 25 dihydroxycholecalciferol and activate it into 125 hydroxycholecalciferol, which is the active form of vitamin D. It will also increase the reabsorption of calcium, decrease the reabsorption of phosphate, and in the urine, thus in the urine we will have decreased calcium and decreased phosphate. And I would like to remind you with my mnemonic here, PTH stands for phosphate crashing hormone. Okay, that's kidneys. Let's go to bones. Now, into bones, but here, this effect here, not only PTH has work here, PTH and vitamin D. That's why PTH activates vitamin D in the kidneys, because I want you to imagine vitamin D as its assistant or helper in the effects on the body generally. So vitamin D will go to the bones alongside with PTH, will go to the bones, increase bone resorption by activating osteoclasts, طبعا indirectly, because PTH receptors are on the osteoclasts. PTH receptors are on osteoclasts. So PTH will activate osteoclasts for a little amount of time, and then osteoclasts will activate osteoclasts and will start bone resorption and will start secreting calcium and phosphate to the blood, increasing phosphate and calcium. Also, vitamin D will go to the intestines and increase the absorption of calcium and phosphate. Okay, that's the third organ right there. Vitamin D here. So now in the blood, in the blood, we have high calcium and high phosphate, or let me say normal calcium, because we had hypocalcemia. Now we corrected that, and now we have normal calcium, but we have high phosphate. That's why PTH activated phosphate excretion. Now the kidneys, now the kidneys will get rid of the excess phosphate in the plasma, and everything will get back to normal. I hope this is clear. This is the whole lecture, by the way. Now, negative feedback inhibition here quickly. Activated vitamin D has a negative feedback inhibition on the parathyroid gland, on the parathyroid synthesis and secretion. Because if we have high vitamin D, why would we need the parathyroid hormone? One of the functions of parathyroid hormone is to increase vitamin D. So we have vitamin D, خلاص, we don't need parathyroid hormone. That's why low levels of active vitamin D has a positive effect on the parathyroid gland and the parathyroid hormone secretion. But I explained all of this. This is basically explaining what I said, repeating exactly what I said. If we want to go over them really quickly, adenylyl cyclase, you have to memorize which hormone has cyclic AMP, which hormone has cyclic GMP. There is a mnemonic on first aid, check it out. Just quickly memorize them. It will tell you مثلا TSH, cyclic AMP, PTH, IP3, هيك. Every enzyme has its own, every hormone has its own G protein, okay? Okay, this is wordly explanation of the coming of this figure, or this, at least this, yeah. No, this paragraph. This paragraph basically is the wordly explanation of this figure. What is this figure? This figure is explaining how is parathyroid aiding in the excretion of phosphate in the kidneys, in the proximal tubule specifically. PTH combines to the GS series, to the GS when the GS protein is activated, or when adenylyl cyclase catalyzes the conversion of ATP to cyclic AMP, which activates a series of protein kinases, activated protein kinases. See, it binds here, GS activates adenylyl cyclase, which is adenylyl cyclase will convert ATP to cyclic AMP will activate protein kinase will start some phosphorylation will start phosphorylation in order to inhibit the channel which transports sodium and phosphate from the urine, or reabsorbs sodium and phosphate from the urine into the blood. This will be inhibited by this phosphorylation, which in the first place started with PTH. Action on the bone, I explained this effectively, but let me go over it really quickly, because I want to make sure that you understand that the receptors are on the osteoblasts, not osteoclasts. So PTH, in bone PTH receptor are located on osteoblasts, but not osteoclasts. PTH bone formation is by a direct action on osteoblasts. This brief action is the basis for the usefulness of intermittent synthetic PTH administration in the treatment of osteoporosis. That's why in osteoporosis, he's trying here to say in osteoporosis, sometimes they administer intermittent synthetic PTH. Why? Because the first effect, the first small effect or short effect of PTH is on osteoblasts, which is bone building, not bone resorption. Okay. In the second, long-lasting action on osteoclasts, PTH causes an increase in bone resorption. The second action on osteoclasts is indirect and mediated by cytokines and released from osteoblasts. These cytokines, you see, this is what I explained. It's firstly, the receptors are on PTH on osteoblasts. Once osteoblasts are activated, osteoclasts will then be activated, and the long-term, long-lasting effect will be on osteoclasts, not osteoblasts. So osteoblast activity is just brief activity. Okay, that's it. The overall effect of PTH on bone is to promote bone resorption, delivering both calcium and phosphate to extracellular fluid, hydroxyproline, and that's it, okay? Now, on kidneys and small intestine. On kidneys, I said we have three effects or two major effects. The first one is inhibits phosphate reabsorption by inhibiting sodium phosphate co-transporter, the one I showed you in the figure and explained I explained the whole process of cyclic AMP, and then adenine cyclase converting ATP to cyclic AMP, then and by the way, the excess cyclic AMP will be secreted in the urine. And the second function is stimulation of calcium reabsorption on the distal convoluted tubule. The third effect is activation of vitamin D. This is very important, okay? Small intestine in the small intestine, PTH does not have a direct action. However, indirectly through vitamin D, through the activated vitamin D that PTH stimulated the 1-alpha hydroxylase to activate, okay? That's it. Same thing. Okay, so let's put this into action. Oh, basically, this is the same exact figure I explained at the beginning, but I'm stressing it on again with multiple slides just to make sure that you understood it. Low calcium levels will increase PTH secretion. Increased PTH secretion will have effects on this in the bone, on the bones, kidneys, and intestines. On the bones, it will decrease phosphate reabsorption, increase calcium reabsorption, and activate vitamin D. Activate vitamin D. Okay. It will also increase the cyclic AMP in urine. Why? Because in order to decrease phosphate reabsorption, cyclic AMP had to be activated. Activated cyclic AMP. Where do we go with the cyclic AMP? To the urine. On the bone, increases bone resorption to increase calcium and phosphate. In the serum, calcium absorption in the intestine, you increase calcium absorption, but this is an indirect effect of PTH directly through activated vitamin D. Functions of, again, this is just a repetition in the summary slide. That's why I told you in the beginning, if you will, that slide that I explained at the beginning summarized the following, the whole lecture, basically. Free calcium in the blood, will not repeat it, just read it really quickly. And this is where I got my mnemonic, phosphate trashing hormone, PTH. Here he is saying that this is a page from first aid. Look at what's written here. PTH related peptide functions like PTH. Okay, where is PTH related peptide secreted from? Malignancies, from squamous cell carcinoma of the lung or renal cell carcinoma. That's it. Okay, let's start talking about deficiencies and syndromes and disorders, basically. طيب, we have three disorders or three ways things can go wrong in for parathyroid gland, or generally for calcium homeostasis. Three things. We have three disorders. We have more, but let me explain the basic three: primary hyperparathyroidism, secondary hyperparathyroidism, and tertiary hyperparathyroidism. It's always hyperparathyroidism. Primary, secondary, tertiary. For you just to understand it really quickly, primary hyperparathyroidism is caused by overactivity of the gland. Secondary hyperparathyroidism is caused by some chronic renal failure, and tertiary hyperparathyroidism is autonomous. I'll explain it now. Starting with primary hyperparathyroidism, what do I mean by overactivity of the gland? Basically, overactivity of the gland for any reason. The first and most common reason is cancer. Cancer is an overactivity of the gland, صح? You have cancer, you have a tumor that is secreting PTH, usually due to parathyroid adenoma or hyperplasia of the parathyroid gland secreting more PTH. What are the signs of primary hyperparathyroidism? I want you to think, before we start reading, I want you to think with me. We have a tumor that is secreting PTH. What do PTH do? PTH increases calcium, decreases phosphate. So what will the labs see for primary hyperparathyroidism? Hypercalcemia, hypophosphatemia, basically, and high PTH. So if you draw blood sample from a patient with primary hyperparathyroidism, you'll find his calcium levels very high, his phosphate levels low, and his PTH levels very high as well, because there is a tumor secreting PTH. Okay, and this tumor is autonomous. It's independently secreting PTH without negative feedback inhibition, without positive. It's a tumor. Let's go on. hypercalcemia, hypercalciuria. And we are having calcium excreted in the urine because of its very high levels and high quantities in the plasma. So some of it is being excreted in the urine. And this causes renal stones. And I'll explain why they are highlighted in red now. Polyuria, which is urinating frequently. Thrones. Hypophosphatemia. We explained why hypophosphatemia. Increased PTH. I explained why increased PTH. Increased ALP. What is ALP? ALP is secreted from bones. We have it high because we are having very high bone resorption. We have so much PTH, and that's why we have we have so much bone resorption. That's why if this goes on, osteoporosis will happen. This primary hyperparathyroidism patients are at high risk of osteoporosis because they are having PTH stimulating bone resorption. So something is eating their bones literally, continuously. Okay. A high urinary cyclic AMP, and you know this why this because one of PTH functions is trashing phosphate, and cyclic AMP is involved in this process. Bone pain, now you know why. Weakness, constipation, because no calcium is being absorbed, so this will cause constipation, abdominal pain, kidney pain. Now, what are those red words? Stones, thrones, bones, groans, and psychiatric overtones. This is basically a mnemonic from first aid. This is a first aid page. These are signs of primary hyperthyroidism. Stones, renal stones. Why would a primary hyperthyroidism patient have renal stones? Because they are having hypercalciuria, and renal stones are made of calcium. Okay, one kind of renal stones are made of calcium. So you're having too much calcium in your urine, and you are at higher risk of developing renal stones. Thrones is polyuria. Thrones aslan actually means is urinating frequently, or it has an inside meaning, let me say. Bones, you have bone pain. Why do you have bone pain? Because again, PTH is directly activating osteoclast, which is eating your bones. Groans is constipation. And psychiatric overtones, when we have hypercalcemia for a long time, you would have psychiatric overtones. You would have some psychiatric presentation, let me say. Now, secondary hyperparathyroidism is not due to an overactive parathyroid gland. However, it is because of chronic renal failure. Now, chronic renal disease or chronic renal kidney disease, I want you to imagine it this way. You took renal, but I want to remind you that the kidneys is basically working in the opposite way. So if the normal function of the kidney is to reabsorb calcium and excrete phosphate, this will be the opposite in chronic kidney failure. So in kidney failure, calcium will be excreted in the urine and phosphate will be reabsorbed. Okay, and this is basically this will imply, or this will be reflected on the labs. If you draw blood sample from a secondary hyperparathyroidism patient, you will find his calcium levels very low. Why? Because they are being excreted in the urine because of the kidney failure. Very high phosphate. Why? Because again, the kidney is reabsorbing the phosphate because of the kidney failure. And hyperphosphatemia, again, same thing, yeah. Again, also, yeah, this is another reason why calcium would be low, because of the hyperphosphatemia. Remember, phosphate is always bound to calcium. And when you test for calcium in the blood, you are testing for the active or ionized calcium. And since we have so much phosphate in the blood, all the phosphate is being bound to, is binding to the calcium, the free calcium in the blood, let alone the calcium that is being excreted in the urine. Now you have hypocalcemia and hyperphosphatemia in chronic kidney disease. You will also have high PTH. Why? Because no calcium in the blood. And what is the main effect? Or how will your body secrete PTH when it senses that there is no calcium or hypocalcemia? So hypocalcemia and high PTH. So labs will show high PTH, hypocalcemia, and hyperphosphatemia. طب urine test, what will urine test show? Urine test will show very high calcium and very low phosphate. So the opposite. Now you know why. Tertiary hyperparathyroidism, It's not that common. It's just refractory hyperparathyroidism resulting from chronic kidney disease as well. Very high PTH and very high calcium because of the very high PTH. So it started with low PTH and then it with low calcium because of the chronic kidney disease, and then PTH is being secreted in the very high quantities just to overcome uh, this calcium loss, and this is why this will be effective for some time, and calcium will increase a bit, and this is tertiary hypothyroidism. Now, hypoparathyroidism is quite interesting because it's confusing, and I'm here to make it clear, inshallah. Like, why do we have hypoparathyroidism? Maybe injury of the gland or their blood supply during surgery. For example, someone is having thyroidectomy, and the doctor took out the parathyroid gland بالغلط, okay? And this usually happens. This is a complication, or an autoimmune destruction, or Dijorge syndrome. What are the findings? Tetany and hypocalcemia, hyperphosphatemia. Now, hypocalcemia and hyperphosphatemia because no PTH. The function of PTH is literally the opposite of these. No PTH, what will happen? Instead of hypercalcemia, you'll have hypocalcemia, and instead of hypophosphatemia, you'll have hyperphosphatemia. Two signs related to tetany: Chuvostic sign and Trousseau sign. They are signs of tetany in hypoparathyroidism. What is Chuvostic sign? It's tapping. If you tap the facial nerve here close to the ear, contraction of the facial muscles will happen. And Trousseau sign is occlusion of the brachial artery with blood pressure cuff, carpal spasm. Yani when you're trying to take blood pressure of the patient that has hypoparathyroidism, their carpal muscles will start spasming because you occluded the brachial artery. Like, we have two types of hyperparathyroidism, sorry. Pseudo hyperparathyroidism type A and pseudo hyperparathyroidism, okay? What is pseudo hyperparathyroidism? Pseudo hyperparathyroidism is an autosomal. Both of them, by the way, are genetical disease, so autosomal dominant diseases. One of them is maternally transmitted and the other is paternally transmitted. So the pseudo hypoparathyroidism is maternally, pseudo hypoparathyroidism is paternally. Mutations in these genes. The important thing I want you to know here is what's going on in pseudo hypoparathyroidism basically is that the sensitivity to PTH on target organs is lost. Yani receptors are not resistant anymore. Okay, we have PTH. PTH is being secreted for any reason. Yani if this patient has hypocalcemia, PTH will be secreted normally. Nothing is wrong with PTH secretion. The issue is with the receptor of PTH in the target organ. So in the kidneys, in bones, mainly, and intestines indirectly. So kidney and bones, the receptors in kidney and bones for PTH are insensitive. Yani we have end organ resistance. So we have PTH, but it's mainly ineffective. What will be the signs? We have PTH, so we have high PTH levels in the blood. What about calcium? We have low calcium, hypocalcemia. Why? Because we have PTH, but it's not effective. It's not doing its functions, okay? So hypocalcemia and hyperphosphatemia. Let's check. So we'll get back to physical examinations really quick. Go to labs. High PTH. We have PTH normally. It's being secreted. Low calcium because PTH is not affected. It's not doing its job. And increased phosphate. Why? Because again, PTH is not doing its job. The job of PTH is to increase calcium and decrease phosphate, and this is the opposite happening here. Physical examinations, Albright hereditary osteodystrophy, which is shortening of fourth and fifth digits. Look at the fourth and fifth digits here are short relatively in relation to the first and second digit, with a short stature and a round face and developmental delay. Okay, so a question might arise, pseudo hyperthyroidism, or what would the wait, the lab results in a pseudo hypothyroidism patient are the same lab results as the secondary hypoparathyroidism, صح? Increase hypocalcemia, hyperphosphatemia, and high PTH. hypocalcemia, hyperphosphatemia, and high PTH. What's the difference? How can we differentiate? Basically, physical findings first. First of all, secondary hyperparathyroidism is not an autosomal dominant or a gene issue. It's just an issue with your kidneys that are causing hyperparathyroidism. Here, there's nothing wrong with the kidneys except the receptors are insensitive. No insensitivity in the receptors in hyperparathyroid in secondary hyperparathyroidism. You look at the Albright hereditary osteodystrophy, shortened fourth and fifth digits, and the short stature. All of these are signs of genetic gene mutation. We don't have gene mutation in secondary hyperparathyroidism. And the main difference in a clinical scenario is the chronic kidney disease. The main issue in secondary hyperparathyroidism is chronic kidney disease. And if you replace the kidneys or you gave a drug that solved the issue of the kidney disease, everything will go back to normal. No chronic kidney disease here in pseudo hyperparathyroidism. No signs of chronic kidney disease here. Okay, so the problem is not with the kidneys here in pseudo hyperparathyroidism. The problem is with the receptor. You need to find a clue in the question, in the scenario that leads you to a hint يعني that the receptor is the issue. Pseudo hyperparathyroidism is basically very close to this. However, no or without organ resistance. It's no organ resistance here. No end organ resistance to PTH due to normal maternal allele. The resistance comes from the maternal allele, not from the paternal allele. Maintaining the renal responsiveness of PTH. Labs will be normal here. Yani pseudo hypoparathyroidism will have normal labs, except you will have physical findings of the same physical findings, osteodystrophy, Albright osteodystrophy, and you will have a gene mutation that is coming from the paternal side, paternal allele, but it's not making that a huge effect on the PTH receptor, just those, except for the physical findings. Familial hypocalcemia, you have to understand the difference, okay? You have to memorize these and understand them, don't memorize them, okay? Medicine is about understanding more than memorizing. And then hypoparathyroidism, and just differentiate between pseudo-hypo, and hyperparathyroidism, since they have similar labs, and I hope I made that clear. Familial hypocalciuric hypercalciuria is coupled with it's just defective G protein, and defective G protein, hence you will have sorry, it's a defective G protein calcium sensing receptor in multiple tissues like parathyroid and kidneys. So you will have higher than normal calcium. You need higher than normal calcium in order to suppress PTH. Okay, that's it. This is a table from first aid that shows you different lab values. You go over it really quickly. I explained everything. Secondary, look at secondary hyperparathyroidism and pseudo hypoparathyroidism. Similar labs, decreased calcium, increased phosphate, and increased PTH. They are the same, but I explained the differences. The differences is chronic kidney disease, CKD. Okay. Vitamin D deficiency is interesting. Decreased calcium, decreased phosphate, but increased phosphate. We have high phosphate, as I mentioned this in the beginning, of vitamin D deficiency is a reason why PTH could be high, because vitamin D deficiency stimulates parathyroid gland to secrete parathyroid hormone, and you will have less calcium because vitamin D deficiency has a major role in increasing calcium, but you will have very low phosphate levels. Why? Because you have very high phosphate. You will have very high PTH, which is phosphate latching hormone. Okay. This is a grid where you can differentiate between primary, secondary hyperparathyroidism alongside with generally hypoparathyroidism. See, look, the y-axis is PTH, the x-axis is calcium. Look at the normal, it's seated in the middle. In primary hyperparathyroidism, you will have high calcium and high PTH. Remember the reasons why? Because of a cancer or a tumor that is secreting PTH. Secondary is not because of a tumor or an overactivity. It's because of chronic kidney disease. So you will have low calcium because of the chronic kidney disease. That's why we have high PTH, because we have hypocalcemia. The normal is here somewhere, normal ranges of calcium, normal ranges of PTH. Okay. PTH independent hypercalcemia. This could be for this has many causes, but one of them is cancer. PTH independent hypercalcemia. We have a cancer that is secreting calcium. Imagine this. Imagine you have a tumor that is secreting calcium. You don't need PTH. Okay. You will have high calcium, but you will have low PTH. Why? Because this calcium is inhibiting PTH. Hypoparathyroidism is due to resection. You will have low PTH because you resected the parathyroid gland, and low calcium because no parathyroid hormone to increase calcium levels. Calcitonin. Calcitonin is secreted by, if you attended my previous lecture, I told you I have a dedicated slide for calcitonin, and this is it. You go over it really quickly. It's easy. It's secreted from peripheral cell of the thyroid. What it regulates the calcium levels as well. However, it regulates high calcium levels, not low calcium levels. And hypercalcemia, not hypocalcemia. Hypocalcemia is regulated by hypocalcemia is regulated by PTH. However, hypercalcemia is regulated by calcitonin. It goes and it decreases bone resorption, and it increases calcium levels in the bones, and builds bones basically. You can read this. This is very easy. I explained it many times. Well, this is the vitamin D cycle or process. You have vitamin D in your skin. UV light in this form. UV light changes it into cholecalciferol. Cholecalciferol can come from diet as well to the liver in order to change into 25 hydroxy cholecalciferol. This is the inactive form of vitamin D. It goes to the kidneys. 1-alpha hydroxylase activates it, or it stays inactive in the same form. But if 1-alpha hydroxylase activates it, it becomes 125 dihydroxy cholecalciferol. What stimulates 1-alpha hydroxylase is hypocalcemia, hyper-PTH, or phosphate. This is the role of vitamin D. Read it. This is in the kidneys, intestines, and bones. I explained it, and this what happens in vitamin D deficiency. Vitamin D deficiency in adults is called osteomalacia. In children, it's called rickets. Rickets in children, osteomalacia in adults, and that's it. You could have vitamin D resistance. It will have the same effect as I explained before. And that's the end of my lecture. This is a feedback. Please scan the barcode and give me the feedback I deserve. And again, this is my information down here. Please don't hesitate to contact me for any question. I'll be more than happy to help. That's it for me. I hope you the best of luck. Assalamu alaikum wa rahmatullahi wa barakatuh.